Good afternoon, everybody from beautiful San Diego. Thank you for joining us and spending this hour with us. My name's Gordon McCord. I'm a professor of economics here at the School of Global Policy and Strategy, and we're delighted that you're joining us for this first in a series of webinars that's being organized as part of the 30th anniversary of the school. And we're very excited to organize these things as a way to be in touch with friends of the school, alumni, and other friends who are near and far. And so thank you for joining us. The topic of today's talk or series of talks is an area of a lot of growth for the school, which is the area of global health. And we're showcasing it as an example of how much the school has grown, both thematically, but also in terms of the numbers and diversity of the faculty and their research interests, but also all of the exciting ways that the students are contributing to research and all of the career opportunities that are opening up to our alumni. We'll be able to touch on those three topics. I myself work on issues of global health and bringing lots of methods, especially from the spatial analysis side, to understanding how global health is changing in the developing world, what's the relationship between environmental factors and how those are affecting infant mortality, how the diffusion of agricultural technologies and those improvements are affecting people's health. I also do a lot of work with the UN system on financing of health systems around the world, and we could circle back to some of those topics if they're of interest when we get to the Q&A. But today I'd like to showcase my colleagues and my friends. The first will be Professor Josh Graf-Zivan. He'll talk about research and lots of exciting things going on in the health space at GPS and UCSD more broadly. After that, we'll have a current student, Carmen Sainz Villalba. She'll be talking about the training that she's receiving here and her work as a research assistant for professors doing work in global health. And finally, we'll hear from Emily Fakey London, who is currently in Washington, D.C. at CSIS doing lots of exciting work in global health. And she'll talk about her professional trajectory and how GPS positioned her for that professional growth. So we're excited to hear from all of you. So I'll give the floor first to my colleague. Professor Graf-Zivan is a professor of economics here at the School of Global Policy and Strategy, and he works on a diverse set of issues both in and out of health. But he's been one of the pioneers in building efforts in expanding GPS's expertise, particularly from the economic side, towards lots of topics that link to the natural sciences. And I'll let him talk not only about his research, but about lots of exciting things that are going on at GPS and UCSD with regards to health. So please, Josh, go ahead.
Great. Thanks, Gordon. Thanks for that introduction. Nice to be virtually speaking to all of you. I'm going to maybe briefly touch upon three areas in which I am active research-wise in the spaces that touch upon global health. And then, as Gordon advertised, say a little bit more about GPS and where GPS is going in the space, and time permitting, maybe say a little bit more about both where UCSD has gone in this space in the last, say, half decade or so, and where it is likely to go in the coming decade. My research in global health sort of falls into three broad categories. Again, remembering that I'm an economist. Whether that makes you smile or grimace, I'm not sure. But that means that I take a very particular set of tools and perspectives to global health problems. And my work in this space has really started a very long time ago, and was focused largely on thinking, so much of the work that happens, at least that used to happen in the space around economics and healthcare delivery, was focused to a great degree on cost effectiveness of a variety of strategies or programs. So understanding what are the benefits that are delivered in a clinical sense, understanding what the costs of providing that care might be, and thinking about what are reasonable activities that we might be able to deliver in a resource poor environment. And that's extremely important work that continues both within the school and more broadly in the profession. My interests were much more focused on thinking about the economic returns to health, and therefore the economic returns to healthcare in an environment that's much broader than the narrow clinical sense. And so to sort of give you an example of what I have in mind, my early work was focused on HIV in sub-Saharan Africa. And what that research was largely focused on was understanding what the economic consequences of a dreadful disease like HIV is on not just the individual who's suffering from that disease, which we know is suffering greatly both in economic and in clinical terms, but on all the ramifications that has for their household and their communities. And so in the work that we've done, we've looked at how having disease shocks in the household impacts the labor supply of other members of the household. It impacts the schooling decisions for children in that household. And so in that sense, one can think about the health, particularly in these resource-poor communities in which insurance options are very limited. We can think about the health of one individual in a household as inextricably tied to the welfare of other members of the household and having long-reaching intergenerational impacts. And when one recognizes that, one can easily see that the returns to investments that can improve that health or avoid those health shocks, or for that matter, insure against those health shocks, offers tremendous returns in this environment. And we have lots of work in this space, and we continue to do lots of work in this space, largely in sub-Saharan Africa. The second piece of my portfolio has a very economic feel to it. It will sound familiar to many of you who've passed through the halls of GPS, or its former incantation as IRPS, and that is the study of incentives in healthcare systems and how can we improve upon or manipulate incentives in healthcare delivery systems, whether they're in developing countries or in developed countries, to improve outcomes. And so one exemplary study that I'm involved in now is some work in Senegal in which we're engaged in both manipulations on the provider side as well as on the patient side to try to pay providers based on outcomes, basically give providers bonuses for doing the right thing in an environment in which they're not well monitored, to give patients incentives to come in for care that we know is valuable, but they underconsume for a variety of reasons, not least of which because it's costly to get to the clinic, and often when one gets at the clinic, the doctor's not there, and to look at how rolling out those incentives in a variety of ways, in fact, rolling out demand side alone, supply side alone, the intersection of those, in this case in Senegal, to see what we can do to improve outcomes in a place where maternal and child health is actually performing very poorly by global standards. The last piece, which connects to a broader agenda on my side, which is not just one pertaining to global health, or at least if it pertains to global health in the true global sense of it, both in the developed and developing world, is looking at the impacts of pollution on health. And that work is largely focused on understanding, we know that pollution is bad for human health, at least in high quantities. My work is largely focused on looking at much lower levels of pollution and the impacts those lower levels of pollution might have on what we might call subclinical effects. That is, how does low levels of pollution affect a range of human capital outcomes, ranging from labor market outcomes to learning, to cognitive performance, and a range of things that matter in an economic sense. And if those things manifest at low levels of pollution, even if they're very modest effects, they may add up to very large effects in total because they affect such a wide swath of the population. So that's my research agenda in a nutshell. Let me say a few things about GPS and then talk a little bit more about campus in general. So for those of you who don't know GPS well or haven't been at GPS for a while, you might be surprised to hear us talking about global health. This is relatively new for the school, but I view it as something that's a very natural outgrowth of the direction the school has been moving for quite some time. The school is really recognized as an institution. As an institution, we've always prided ourselves on our methods and on our institutional depth of knowledge. That is, we know the places we're working in very well, And we also really think hard about the methodologies we're going to apply to understand those places. The new feature of GPS, if you will, and it's not so new, is one that's really focused on leveraging a lot of the talent that exists at UCSD more generally, and in the field even more generally, which is the notion that technology and science and the interface of technology and science with well-designed policies in settings in which you understand the institutions and the incentives embedded in those institutions are critical for prosperity in the 21st century and really helping lift the bottom billion out of poverty. And the moment you start to think about the bottom billion and you start to think about poverty and you start to think about development, it is sort of untenable to not be engaged in a variety of policies and policy questions that relate to health and well-being, because of course one of the great threats to prosperity in the poorest places in the world is both low levels of healthcare provision and lots of threats to health in an environmental sense. And so the school has made a concentrated effort to build out that expertise. I work in this space. Gordon McCord, who introduced us all, works in this space. Another colleague, Tivrat Garg, works in this space. Carmen's going to tell you about the work that she's doing in this space. Emily's going to tell you about the work that she's doing in this space as a graduate of this program. And it's a really exciting growth area for us. It's exciting for GPS because it naturally connects to a lot of our science / policy domain expertise. It also connects to a growth area for the campus. We live in San Diego, where biotech is a major part of our community. Information technology, ICT, is a big part of our community, and those two things connect in a very interesting and nice and provocative way when we think about global health delivery in resource poor environments. We also stand poised, although it may be some time before it comes to fruition, to launch a new school of public health at UCSD. We envision that as being very complementary to the efforts we're engaged in here at GPS, and we look forward to seeing how that evolves as the new school takes form and shape and unfolds. I'm going to pause there so there's enough time for my colleagues to speak, and then we'll stick around for some more questions at the end. Thank you.
Fantastic. Thanks, Josh. So up next is a second-year student in the master's program in public policy, Carmen Sainz Villalba. And Carmen, tell us about what you're working on.
Thank you, Gordon. I have seen health issues in all of my classes at GPS, actually, from the cost-benefit analysis to GIS, Professor McCord's class, and also in the QM sequence, in which, for example, Professor McIntosh also deals with a lot of issues concerning health. And currently, well, I started last year working with Professor Tivrat Garg on how coal-fired plants pollution affects the test scores of children. We are at a very early stage of the research project still, but I have been collecting data from the demographic and health surveys in a lot of the developing countries like Ethiopia or India. And the tools that GPS provides to study this health problem are very important, because for example, in GIS, the distance to a well, the access to water, for example, can be measured. And for example, in my work with Professor Tivrat Garg, the distance to the coal-fired plant is a huge factor in assessing whether the children is affected more or less to this pollution. So I think that's what I have to say about the current stage of the research project, because it's still in the very early stages.
Thanks, Carmen. And what about from the statistical analysis side and what you're doing in the QM sequence, and maybe how that connects to the future you'd like for your career?
From the QM sequence, in the QM3 with Professor McIntosh that we see the way that we do the panel data sets, the way to identify the causal relationship between pollution and the effect on children's health is very important, because we want to assess the validity of our research, of course, and we want to be more than just a correlational relationship between the variables. So it's very important, because I've seen in all the classes that I've seen health are the quantitative courses, the ones that actually put these topics into place. So, for example, also in Professor Joss' graph 7 class in environmental and regulatory economics, we are seeing these problems, this externalities of pollution, on a quantitative way, because we want to measure actually the impact that this is going to have on people's health. Like, we don't want to be qualitative and just say that it's important. So,
excellent. Thank you. So last for this opening set of remarks, we'll turn to a former student of GPS, Emily Fakey Munden, who graduated in the class of 2016, 2 years ago. And she's went off to Washington to do great things that I'll let her tell us about. So Emily, tell us about what you're working on and what you've been doing for the last 2 years, and how GPS set you up for that.
Happily. Thanks, Gordon, and I'm happy to be here. Thank you to everyone for joining us tonight for me, afternoon for you. I'm sure the weather's a lot better there in sunny San Diego than here in Washington. So as Gordon said, I graduated in 2016. I started working with the Center for Global Development, which is another think tank based in Washington, D.C. And then my manager, when I was an intern here at CSIS during between my first and second years at GPS, reached out and said, "Hey, do you know anything about health security? I'm launching a commission and I'd really like you to help lead it here from the CSIS office." So I started that job in January of this past year. So I direct the CSIS Commission on Strengthening America's Health Security, a very apropos name for the current times. So this commission really focuses on the intersection of global health and national security, which is a great fit for CSIS as an institution, which is a foreign policy think tank with a 50-year history working in defense. So we're really leaning on our institutional legs and connections into the national security community to elevate global health as an issue that, just like bombs and bullets, has the same impact on American lives, livelihoods, and economics. So we have 5 focus areas in the commission, which are high-risk disease outbreaks, so think Ebola, for example, medical countermeasures, which can be diagnostics, therapeutics, vaccines, antimicrobial resistance, which many of you may be familiar with, but is essentially drug resistance. If you go to the doctor and get an antibiotic, many common infections now, like gonorrhea, antibiotics are no longer effective at combating those, and we're going to 3rd and 4th line antibiotics, and for some infections, actually no longer even have drugs in the arsenal that help beat those. We also work in evolving biotechnology. So as Josh said, this is a rising area just in the last couple of years, and our commission is really focused on, from a policy perspective, what is the risk versus reward, and what should the US government's stance be? So there's obviously great rewards to be reaped from things like genetic manipulations, but we need to be very cognizant of risks involved as well, especially when we're thinking about intentional biological attacks, where things like engineered smallpox are of great concern now to the national security community. And then the final, I mentioned we have 5 areas, that was 4. The 5th area is something we've been calling the disordered world. And that is just taking a look at, if we think about the world in 2018 versus 2008 versus 1998, it looks completely different from a health policy perspective, especially for the US. So we're not just thinking about conflict, about refugee crises, but also malgovernance, lack of governance, issues of extreme distance, and how those mediate issues of access when we think about health and health security specifically. So I want to give a couple of examples of what that looks like, because I think that might be an area that's of most interest to GPS students, alumni, anyone else who's joining tonight, and really illustrates well how my GPS training has dovetailed with what I'm currently doing now. So we just wrapped up today production on a video on the health security dimensions of North Korea. We've been looking at really high levels of multi-drug resistant tuberculosis in North Korea and examining what could happen in a couple of different scenarios, for example, state implosion, or the lack of, or the total cutting off of supply chains of health supplies into the country, which is currently happening. With most of the small NGOs that were currently having access in North Korea, their access has now been completely cut off by the US government. We know from satellite imagery, for example, that the Chinese are already building refugee camps and quarantine centers along the border with North Korea, and then playing out behind closed doors with policymakers. What is the impact? What do we estimate the impact of this might be? And what plans can we make a priority to address this? Another example is the current Ebola outbreak in the Democratic Republic of the Congo, which is taking place in an active conflict zone. So we've been convening private groups with the WHO, implementers and operators currently working in the region, and then US government decision makers. As some of you may know, the US is not allowing any of its workers to work within the area of the active outbreak in Beni and DRC, which is a stark change from US policy previously, and the security environment does not really warrant that level of pulling out US CDC workers when their expertise is so desperately needed. So our commission and our group is trying to facilitate that dialogue and then author some commentaries to try and suss out the issues a little bit better and understand, again, mediating factors like the upcoming elections in the DRC. What impacts do we expect those to have in the trajectory, the epidemiological trajectory of the outbreak? In terms of running the commission itself, this is probably where my GPS preparation deviates a bit in terms of what I have needed to learn along the way and wasn't taught as much in class, but something that, as I mentioned, I did an internship between my first and second years, and also did an internship during my first year. And I think that experience is what has really allowed me to do the directorial work of leading this commission. We're co-chaired by Julie Gerberding, who was a former head of the CDC under George W. Bush, currently works as Chief Patient Officer at Merck, and then our other co-chair is Senator Kelly Ayotte of New Hampshire. So we also have military leaders, 6 current members of Congress on a bipartisan basis, and other members of the private sector, and then folks in global health who've been around for a long time, like Mark Dybul. So managing this group, it's 23 different individuals, is quite the challenge, and then being sensitive to the political realities, both in their careers and public personas, as well as, you know, being actively engaged with legislation that's moving through Congress, and making sure that all the work that we're putting forward is not just another dusty report from a think tank sitting on a congressional staffer's shelf, but is really being taken into account in the active dialogue that's going on, and making its way into bills that are actually being passed. In terms of GPS preparation that helped me get here, I actually am not doing any quantitative analysis in my current work, which has always surprised me, because my QM classes, my GIS classes were my favorite ones as I was going through school. And as I entered CGD and was thinking about my future career, I really wanted to make sure that, like what Carmen is doing now, that my work I'd done at GPS was continuing into my current work. That's actually not the case. So the skills I'm really leaning on now are from classes like PMP with David Victor. I actually lean a lot now, as I was describing with our work in this disordered world, on what I learned in my state building class with Professor Jesse Driscoll, and my lessons from all of you really on being able to explain technical concepts succinctly and in a really engaging way that a layperson can understand what I'm talking about when I say something like epidemiological trajectory, that their eyes don't glaze over, right? I can explain the evidence in a clear and compelling way and be able to write on a really quick turnaround and in many different voices. So I think something I'd under-recognized in my GPS training was how I actually was asked to write in all of these different ways and do so quickly and to the point. So that's been something that I've absolutely relied on. Hopefully in the future, I will get to use my QM skills some more. But one thing I did want to mention is, I mentioned we've used a little bit of satellite imagery on the Chinese-North Korean border, and something we're thinking about doing maybe in this DRC Ebola outbreak context, but potentially if another outbreak does arise in the future that has less forest canopy cover. We are working with a group that has the ability to see people and granularity to the level of license plates. And we're considering if we would be able to use satellite technology to examine how quickly an outbreak is spreading and the level of response that's happening within different epicenters, especially in somewhere like an active conflict zone where the data and the intel that we're getting from the ground, if you're not sitting within the situation room, wanting to be able to ground truth that and provide the larger community with the best possible information. I think I will stop there, but happy, of course, to take questions.
That's fantastic. Thanks so much, Emily. Before I say anything else, let me just tell all the attendees who are here that you're welcome to start submitting questions via the question and answer tool that's built into Zoom, and we will all moderate the questions and put them to our panelists. So while all of you start thinking of questions and putting them in, let me say two things. First, we've heard about an amazing breadth of activities in terms of topics that are related to global health, as well as a number of professors' names, just to give you a feel. You've heard, Carmen talked about the fact that both Craig McIntosh and Tivrak Garg are doing health. Obviously, Josh Graf-Zivand is doing work on health. In terms of pollution, Professor Jen Burney is doing work on health, on how PM 2.5 spread all over the developing world, maps quite closely to the spatial distribution of infant mortality. And so it's just, just thinking out as I was listening to Emily talk about defense issues on and health. Lauren Prather and I are working on a project thinking about how Americans form opinions about foreign aid vis-a-vis self-interested arguments about international health issues. So if you prompt people to think about global epidemics and the US investments in foreign aid abroad, in part finance sentinel surveillance systems so that we understand that new epidemics are arising, new zoonotic diseases, that those things are in the direct US interest, how does that conversation move the needle or not in terms of a person's opinion vis-a-vis support for international aid? And I myself do a lot of work on maternal and child health, which was the title that we gave to this talk. All of us touched on that in different ways, but I'm doing work on community health worker systems in sub-Saharan Africa, trying to understand how very cost-effective systems with people who are trained for only 6 weeks and come from communities who are quite disconnected from the main public health infrastructure, that in fact they can take care of over 80% of the health burden in some rural parts of Africa. And so if you're thinking about, we can't afford nurses and doctors out in rural areas of Africa. In fact, a person who's from the community, has a high school level education and gets 6 weeks of training, can deploy a rapid diagnostic test for malaria and treat a sick child, can give oral rehydration therapy to a child with diarrhea. And if you start adding up these very easy things that constitute most of the health burden and don't require somebody with sophisticated medical training to solve, you can start thinking about a very cost-effective system that we're thinking of, that we're working on scaling, and the government of Ghana is interested in scaling this up nationally. And that then dovetails with other kinds of questions in terms of, for example, I work with UNAIDS on thinking about how we're going to meet this goal of having 90% of people who are HIV positive around the world know their HIV status. that's a big question in rural sub-Saharan Africa, where you don't have all of the normal health infrastructure where people can go and get tested somewhere whenever they'd like to do that, or go to a pharmacy and buy a home diagnostic kit, kits that are becoming increasingly available. And so thinking about how community-based systems can increase access to health, and a piece of that access is HIV testing, and what does that mean in terms of meeting global HIV goals. So just to give people, as they're thinking about their questions, a flavor of everything that's going on here at GPS, and get all of you excited. So I'm going to start reading through some of the questions, but in the meantime, let me ask the first to my colleagues, which is, what would you say to a young person who's thinking about going to grad school and is interested in global health topics? What would you say about considering GPS? Is GPS a good place to come if your interests are in global health? And Josh, perhaps you could talk about that from the point of view of international health, people interested in doing good work abroad, and Emily from the point of view of people interested in domestic U.S. issues on health, Carmen from the point of view of current students. But what would you tell a young person who's thinking about grad school?
Yes, I'll go first. So the short answer is there's a lot to think about if you're interested in doing something in global health and you're thinking about going to graduate school in global health. I'm biased, of course, as everyone on this panel is, but I think GPS has a lot to offer in that space. Perhaps it's useful to say for 2 seconds that prior to my career here at UCSD, I spent 10 years on the faculty of the School of Public Health, so I do understand in some sense what the other degree offerings look like. I think one of the great assets of this program is that it is so fundamentally grounded in methodology, and more important than methodology, because that makes it sound only quantitative. I don't think it's only quantitative that matters. It is grounded in a systematic way of thinking about systems, whether they're political or economic systems, and the incentives embedded in them, in a way that is not, shall we say, standard parts of the curriculum in any school of public health that I'm aware of. That's not to say that there aren't some challenges in coming here if your focus and passion is global health, and that is in part, if you're interested in particular aspects of global health, you may well need to supplement your education here with some very specific training that is available elsewhere on campus, in epidemiology or in specific disease space or in specific technology space, if that's what you're interested in. My sense, having done this for 20 some odd years, is that the sort of general analytic approach, whether it's quantitative or otherwise, that's the skill set required to develop that analytic approach to problems, and they apply to not just global health problems. That skill set is very difficult to acquire on one's own, and frankly, very difficult to acquire in the workplace. Domain expertise on a particular subject, whether that subject is West Nile virus or Rift Valley fever or CRISPR-Cas9 gene insertion technology, is something one can do with a little motivation and a lot of reading on their own or on the job. But the broad analytic perspective, the way in which one approaches policy problems, and those policy problems span well beyond global health, is something that's hard to learn elsewhere, and something that I think GPS does especially well.
Yeah, I absolutely agree with everything Josh said. And I think from my perspective, if you sort of look at my trajectory post GPS, the breadth of issues I've been able to work in, I don't think I would have been as successful in these positions and getting the positions in the first place if I'd been coming from a strict public health background. I think my ability to, that really stemmed from GPS, and I want to say a few words about how I augmented my GPS education to give me the skills and expertise that I did need to be competitive in a public health oriented job. but my ability to, you know, speak about the political system or legislation moving through, or about our concerns with political economy or incentive structures, for example, being really conversational and be able to demonstrate that I can pick up an econometric paper and tell my boss his top 3 takeaways that he needs to know to walk into his next meeting. That's a skill that really sets me apart from a lot of other students who did not get this more diverse level of training. I did, while I was at GPS, take epidemiology with undergraduates. I saw meetings with professors in the School of Medicine. I do have to, you know, when there are topics that colleagues of mine who have an MPH versus a master's in international affairs, or I work, for example, with a lot of students who worked, who did degrees at the Georgetown School of Foreign Policy, is that correct? Foreign Service, I think. Anyways, I do have to spend a couple hours a week bringing myself up to speed. However, I think the GPS education gives you the perfect springboard to be able to do that, because we really, I mean, it's really ground into you. If you don't know it and you have a big question in class, you go look it up, you figure it out, you ask questions when you need to, but don't be afraid of that hard work going from 0 to 60 on a topic that may seem technical, it might seem scary. You are totally capable of finding out that information for yourself. So I'm very happy really with the breadth that my GPS education gave me springing into this career.
Well, I definitely agree with Emily and Professor Graf-Steven, because one of the reasons that I am currently in GPS is because of their quantitative and methodology classes, as Professor Steven said, and the reliance on not just looking at public policy questions, but the impact, the focused on how much is the impact and what is actually the number that actually policymakers are looking for in every questions, because that is very compelling to say this is the impact and this is all of the things that we can do to reduce or increase certain things. And also another reason that I think GPS is very good in this aspect is the multidisciplinary approach that it has, because you can see public health not only in the quantitative sense, but also in the qualitative sense of how to convey it to politicians, or like how the other people in other fields look at it. And so you have this basket of tools that you can gather from to answer these very important questions.
Great. Thanks to all of you. Carmen, let me stay with you first on the next question. That we've received 2 or 3 questions that are asking for advice about the summer internship that students do after their first year, and how best to think about that summer internship in terms of a long-term interest in health. So Carmen, for you, what did you do in your internship and how did you decide to do that? And then Emily, for yourself, particular interest in how, you know, people would love to go work at CGD and follow in your footsteps. So what was your internship after during your summer at GPS, and what advice would the 2 of you, and as well as you, Josh, give to students as they think about their internship after the first year?
Well, I was in my internship. I applied to the Robinson Fellowship that GPS gives to work with a professor, and I worked with Professor Tibet Garg on the topic that I mentioned earlier, coal-fired plants and its effect on the children test course. And I also was I also looked into research think tanks. So my focus always was on research and how to basically study a question in a more technical way, because I thought that was like the best way, most compelling way to actually see the causes of the policy questions that arise in a field. So I think that's...
Yeah, so I did my internship between years 1 and 2 here at CSIS and the Global Health Policy Center, which is where I've ended back up. And I think that more than anything is a big lesson I'd want to share with anyone thinking about the internship experience. I remember it being bone-breakingly difficult to discipline myself in the spring, late winter, early spring of my first year to put in the time to do the phone calls with people here in DC, in New York. I remember considering flying to New York to do the requisite coffees with people to get these really competitive internships. And I'm so glad I did, because it panned out in this incredible job that I now get to have, which I'm 100% certain I only got because I interned here previously. All my fellow staff members were also previous interns. So that's maybe CSI specific, but I've heard this same message from lots of other colleagues here in DC that, and you guys have probably heard this now by now, you know, here in DC, and I think in lots of other places, the connections are everything, showing what you can do, what you're made of, and why you are head and shoulders above, you know, the 400 other people waiting in line. And I really want to reinforce how seriously to take these internships, despite all the other competing demands for your time, when it feels really important, of course, to study for an exam, recognizing in the long run that, you know, putting in the time on doing an internship is absolutely worth it. I cast a really wide net, and I basically told myself, San Diego is awesome, I love the beach, but I need to get myself out to the East Coast because I know that I want to get a job in New York or DC, and I need to be building those networks for myself. So if, you know, I think maybe Gordon and Josh can talk about this as well. Something I noticed as I was applying to internships was these epicenters of opportunities, that one of the biggest ones, if you want to stay in the US, is in Washington, DC. Another is in New York, some in San Francisco. Obviously, you can find opportunity anywhere, but really recognizing that to work, stay in the United States and work in global health, you really need to be looking at getting yourself out here to DC, to New York, a couple of these other big cities, but really those are the primary two. And the internship is the perfect way to do that between years 1 and 2. My second year, I actually flew back to DC every month or so, and then every 2 months to stay engaged with research I'd worked on during my internship. I picked up a consultancy, and that's what really allowed me to keep my feet on the ground, keep my face in front of people, and remain relevant, which set me up for my next opportunity at Center for Global Development. So, you know, big financial investment. I was babysitting in my spare time to save up money for the plane tickets, but, you know, it's that continuous incremental investment that, you know, keeps you spanning this amazing opportunity in the West Coast at GPS, but, you know, keeps your feet on the ground here.
So I don't think I have much to add to that, having never been an intern in my life, but having employed them, I suppose I know a thing or two. So I want to echo first that Emily's point about look early, look often, cast a broad net. The only thing that I would say, I think, in my experience, all students underestimate in that search, besides how long it takes, is that you feel it's very easy to feel like, for lack of a better term, desperate. And I think the thing that is important when you think about your internship is that you need to be an active and selective consumer. And by that I mean, don't hitch your wagon to an organization that has a great mission statement that you love. Hitch your wagon to an internship in which the person who is going to be your direct supervisor appears to have a vested interest in making you get better at what you do and learn something. And if that happens, even if the organization isn't perfectly aligned with what you imagine you'll be doing, you're advancing your skill set, you're advancing your career in an experiential learning environment that will serve you well in the career to come, even if it's not the perfect match for what you think you want to do in a substantive area sense.
That's great. Thanks to all of you. So I've got 2 specific questions, and then as in to one of you, to one person, and then one for the 3 of you, and maybe I'll give all the questions at once, and these will be perhaps the last opportunity for each of you to speak if we wrap up in the next 10 or 15 minutes. So first, specific question for Josh. Health is a very, very broad field. How do you choose the topics that you work on? Specifically to Emily, how do you think about the trade-offs between working at a think tank versus a different kind of institution, like a pure research institution? What are the relative frustrations and strengths of each of these different careers? And then a question for the three of you, which is that health inequity, health inequalities is a new lens through which we're trying to understand human society, and then a new dimension along which we're measuring human well-being and how societies are evolving. And so in terms of the work that you do, what's the importance of health inequality? What's the value added of that lens in terms of understanding how to design better public policy in health? Josh, you go first, and then we'll circle back to
Sure. Let me at least start with the question that was directly asked of me, which is how do you narrow your area of interest in a field as vast as global health? I think there's a couple of things to think about. I think there's two pieces of a career in global health, or certainly a research career in global health, or a research intensive career in global health. There are a set of what I would call platform technologies or platform research areas, which broadly apply to a wide range of areas of global health, various disease areas, various topic areas, various health modalities, various countries, and then there are very specific issues. The one thing I can say most definitively, because I do a wide range of health things, and frankly, the level of engagement, the personal level of engagement for me on each of those topics varies by topic. The one thing that I could say most definitively, because it's hard to say how any one person should focus. I think the focus should be both on developing a clear analytic approach, as we've been discussing, as was sort of one of the key features of our GPS education. In terms of specific areas, I think one has to be drawn to the things that are of interest to them because they relate to them on some personal level, because they are drawn to them for some intellectual reason. The one thing that I can say most definitively is for anyone who's going to seriously engage in fieldwork, that is to be in the place that you're going to be studying these things for any substantive amount of time, you really better love the topic, because 85% of the time you spend in the field is either sheer boredom or sheer misery, and it's only rewarded through doing something that you really care about. And so it can't simply be, I have this great opportunity to go study X in country Y, and it's an opportunity, and so I'm going to do it. One, obviously in their career, needs to be somewhat opportunistic. But if you're going to spend 3 months, 6 months, a year on the ground doing something, it really needs to be something that gets you fired up, because the everyday experience of transport not working, of bureaucracies not cooperating, of clinicians not turning up, of survey enumerators making things up, all the things that can drive you crazy, the thing that pulls you through is the passion for what you're working on. And if you don't have the passion for what you're working on, then that's just not going to fly. In contrast, if what you're doing is sort of analyzing, secondary data, which I do plenty of as well, you should be passionate about the topic, but you can be a little less passionate, because if the regressions don't work well while you're sitting at your desk, you can go out and grab a beer. And you haven't lost that much. I mean, you might have lost a lot of time at the computer, but it's a very different experience. I think it makes sense. So I am I'm trying to coin a term. I've been trying to coin it for 15 years and it's never quite stuck. So I'll try here with however many people are left on the call. I'm a big fan of intellectual promiscuity. I think you should try on a lot of different things, a lot of different ideas, test out a lot of different topics, see what gets you excited. If it gets you excited, you will know when you're excited, when you're genuinely excited, and you'll know that's the place where you want to invest. And you should accept that what gets you excited in 2005 might not be the thing that gets you excited in 2011, and that's perfectly normal and acceptable, and no one expects those interests to remain static.
So I'm going to talk a little bit about frustrations, pros and cons of think tanks versus other environments. And I'm glad that you went first, Josh. This took me a little bit to think through how I really see these differently. And I think the one thing I want to highlight is that think tanks, from what I've learned just in the last 2 years, is they're all very different animals. So CGD versus CSIS, completely different institutions and how they approach problems and actually the research that they do. It's a helpful category, obviously, for an institution and a place to work, but I would caution everybody listening who is either reading research from think tanks or thinking about working in one to not just assume that this blanket term sort of is a model that applies to each and every one. I would say CGD, Center for Global Development, was quite similar to an academic institution in a lot of respects and in your role as a junior staffer there, whereas CSIS moves quite further away from that model. We're closer to what I would call a think and do tank, where we're really engaged with policymakers on a daily basis, and much less common to see here the type of long-term, really in the weeds, quantitative analysis that goes on somewhere like Center for Global Development. So that's note number one. Note number two is just focusing on that do term in think and do. And this does apply to, I think, all think tanks. We focus somewhat on describing problems, understanding problems better, but we spend a lot of time just agonizing over what to do about problems and what we can realistically hope to do, especially in terms of political environments. So that can be US based. We can do this in other contexts, especially in foreign policy think tanks. But where our research, where the rubber really hits the road, is answering that question. And that looks, I think, very different from more traditional academic research in a lot of respects. And honestly can be a lot less exciting than I tend to see myself gravitating towards. Wait, no, I want to describe this problem better for people, and I want really to show the evidence base proving that this problem is real, and this is the magnitude of the seriousness. So that's another important deviation. And then finally, I think the products that you produce out of a think tank have quite a wide range. So as I said, we just wrapped on a video. We have a podcast that we produce, and we do a lot more commentary type written products. So 1,500 to 3,000 word products where you're trying to be snappy and compelling, and you're not quite as worried if your technical characterization of a problem or what you propose to do about it is as correct as that you're defining the waterfront of the issue appropriately, all the actors involved, and what we might expect them to do realistically in a defined time period. So those are quite different. Obviously frustrations with both. I think frustrations in think tank world right now, just to be quite candid, are funding has been more and more constricted. You guys may have seen in the news, CSIS was in the news over the weekend in HuffPo. We have not decided yet that we're giving back our Saudi funding. Brookings already decided it's giving its back. This is really since 2015 or so. Every time there's a question with your funding, the independence of your research really comes under a magnifying glass. And that can be really difficult to defend, especially when people don't like the findings. You really have to work hard to prove your independence and how that funding is tied, but you also always need money to fund your projects. So that's a tension, and I think a pretty constant frustration for me. And then also I mentioned earlier with this commission I'm directing, we're trying to get away from dusty reports on shelves, but at the end of the day, we're not lobbyists. So there's an extent to which the arguments that you're making and the evidence that you're putting forth, that really is just going to be a report on a shelf or a video on a shelf, and they do tend to have expiration dates. And so it sort of feels sometimes like a Sisyphean task working in a think tank, like, oh, well, that bill passed and it didn't have what we wanted, so back to the grindstone on putting things forward. So just a couple of details.
That's great. Carmen, since both Josh and Emily punted on the question of health inequalities, then it's going to all fall on you. How do we think about health inequality? How are you learning to think about it in your classes? Why is it important to study the effect that coal-fired power plants might have on nearby populations in terms of understanding broader questions of development? And any last words that you might want to say?
Well, I think that health is key. Like history has shown that improvement in health has increased the growth of a country exponentially. And so that, like in the production function, one of the key factors is human capital. So health is key for the human capital to be present in the growth of a country. So I think in that sense, health inequalities explain a lot in the development of developing countries. And I've seen that in all my classes, actually. I'm taking currently macroeconomics of development with Professor Lagacos, and one of the factors that we look at is human capital. Of course, health is present in that. And in terms of the other classes too, we see it in GIS and QM sequence, as I've said before.
What's in your future, Carmen? What do you hope to do after graduation?
I want to do a PhD in economics, so I want to be more technical into looking at the public policy questions and hopefully shed some light or like research more in the policy, public policy questions and provide more in-depth research for other politicians and other people in the future.
Fantastic. Well, best of luck to you on that process. We all stand ready to help, of course, that goes unsaid. Well, we're at the end of our time, so I'd like to thank, first of all, our panelists for generously sharing their time and their thoughts on all of these questions, as well as our all the folks who joined us virtually. This is an exciting way to do these kinds of events. I'll remind people that we have events all throughout the year as part of our 30th anniversary here at GPS. The next webinar is on Wednesday, November 14th at 4 p.m. Pacific time. And it's titled "What's in Store for Mexico?" and features, among other luminaries, the head of the director of the U.S. Mexican Studies Center here at GPS, Rafael Fernandez de Castro, and that information is now online for you. But I hope you've enjoyed this hour for us, that you've heard what an incredible hub GPS is becoming in terms of dynamic and high quality interdisciplinary research and policy cluster, not only for health, but for lots of other issues that you'll be hearing about over the course of the year. Certainly speaking on behalf of Josh and myself, alumni, others, you're welcome to reach out to us through email if there are issues you'd like to connect on. And of course, we're always happy to hear from you. Thank you so much for joining us. Thank you to the organizers of the event and to our panelists, and we look forward to being in touch. Have a great afternoon.